us. So, Maiko, take it away.
Wow, thank you so much for a very nice introduction. I'm honored to be here. Thank you, Michael, and the staff at PIH for having me here. I wanted to also thank my mentors who have guided me through this whole journey. Of course, Dr. Shirley Sarman. That's us in 2008 when we first went to Japan. She looks way better now than she does in that picture. I don't know. She's like a Benjamin Button. She looks better every single year. And also thanks to my mentors through the Movement System Clinical Fellowship Program at WashU, namely Mary Kate McDonald and Susie Kornbleet, and then of course all of my fellows, current and past. We've got Joanne here, and then of course you guys all know Michael. So everybody's been helping me out through this journey and learning about the human movement system. And all of the faculty at WashU been fortunate to be able to participate in the faculty retreat since 2012, and we have such a good time just every year meeting and discussing new current concepts. So today's goals, I titled this slide's brief intro. I'm going to attempt to introduce MSI Concept in about 10 minutes because I would like to get to the lumbar demonstration. And we have a lucky winner here, Reggie. I don't know if I want to call him the lucky volunteer or the victim, but we'll see. We'll see what we find out. But mainly understanding the key concepts of the MSI syndromes, and then learning the standardized lower extremity movement test. That includes the primary test as well as the secondary tests via the demonstration. And then big key here is understanding the importance of patient education. I think we're all here to learn and understand what's going on with the patients, but it does the patient no good if we're the only one understanding what the issue is and the patient has no clue. So if we can get the patients on board in managing their own pain, I think that's fantastic. So as we all know, the movement system has been included as the identity of our professional as APTA's vision statement. They've updated that, so I hope we all know who we are as physical therapists. And the pros of MSI, just listing out a few things. I sound like a salesperson, but it really helps us guide treatments more efficiently. So as we might have encountered, that medical diagnoses do not always help figure out the best treatments for our patients. So we have to do our own examination to really find out what's going on. It's also easy to communicate amongst therapists, with other physicians and other healthcare professionals about what it is that we're doing. It identifies us as the go-to people for movement system problems. And then isn't it better to find out the cause of the dysfunction rather than really just treating the source of the pain? I'm sure you all had patients coming into you. So, I went to this other physical therapy place and they just put ultrasound, stim, and hot pack, and I never got better in my back or the shoulder. And they could have had a better evaluation to really find out what was going on. Other things like educating ourselves. We have to get ourselves on board as well as other healthcare professionals that there is a big relationship between movement patterns and the pain problems. Okay, so hopefully people are moving better to decrease their pain problems. We understand that non-optimal movements, if they keep doing it for a long time, that'll lead to pain issues. If you're a manual therapist, it helps you guys become super therapists because this gives it a nice framework to be able to use all the tools that you already have. And this stuff is based on anatomy, kinesiology, and motor control. So today, unfortunately, I will not be telling anything new or any specific technique that you can learn. It's all stuff that you already know, but I think we can organize it in a way that makes it more clear to understand what it is we can do for our patients. And finally, in big bold, empowering patients in managing their own pain problems. So it's such a nice moment to see the patients really understand that moment. Oh, if I move like this, or if I do it this way, I don't have pain and I can live my life. And that's when we know that this is going to continue long term. So let's give them some power for improving their life. Really brief. These are not full key concepts of MSI, but I wanted to introduce some of them. The path of least resistance. I just realized that I forgot to bring my TheraBands, but if I had a thick purple rubber band and a thin orange band tied together and I were to pull it apart, we all know that the orange one's going to start giving first before the purple one goes. Okay? So the body likes to take the path of least resistance. So you can imagine if I had like an orange like TheraBand along my abdominals and then the purple like TheraBands along my hip flexors, if I try to extend my hip, I think I'm going to extend my lumbar spine before my hip goes. Okay, so appreciate that it's going to move where it's easiest to move from. And we'll find this out maybe on Reggie as we do different tests like prone knee flexion or the 2-joint hip flexor length test. Another important concept, so the path least resistance leads to the idea of relative flexibility and relative stiffness. So relative flexibility, we're talking about what joint is moving first. So as the patient does trunk forward bending, is the hip going first or is the lumbar spine going first? And that we would consider the inter-joint relative flexibility. We can also think about intra-joint relative flexibility. So whether within the hip joint, is the anterior part going first or the posterior joint going first? And that might lead to a diagnosis like femoral anterior glide or femoral posterior glide. Then we have another concept called relative stiffness. So this we're talking about muscles and soft tissues. So how stiff are these structures compared to other things surrounding it? So many times I've tested in supine patients' pec minor length tests. And I'm thinking, gosh, it takes a lot of energy for me to put the posterior acromion down onto the table. Or, wow, it went easy, but then I'm looking and like the lower rib cage is about to poke into the ceiling. And I'm like, I think I just stretched out the abdominals instead of the pec minor. So these are things that we need to pay attention to as we go through each test. Day-to-day activities. This is so key. In the end, we have to really help out the patient's daily lives. So really, my first day, I have to understand what are they doing every single day? What's their job? What do they like to do? What are their habits? So let's become a super observant person so that we can help correct either their non-optimal repetitive movements or non-optimal prolonged postures. So this is a joke that Shirley said in one of her many courses. And the joke goes, muscles and the body have not taken kinesiology class. and it's so true, because when we read the kines textbook, you know, here are how the body is supposed to move. But when you meet a patient, like this is my patient who had right shoulder pain, and he's just weight shifting on the treatment table from side to side. And clearly, his serratus anterior did not sit through a proper kinesiology class, or maybe went on vacation. So this is an issue. But when we see impairments like this, I have to start thinking about, well, why does it move that way? You know, it's the why part that makes this job really interesting. This is a guy who, a high school football player. He likes to do deadlifting in the gym. And this is without the weights. The left side was his preferred pattern. And I really tried to attempt correcting his mechanics. The right side is still not the best. But these are things that he's going to continue doing anyway, so might as well make it all look better. Not completely restored, but certainly his lumbar extensors, you know, are not the first thing that's going to lift him up, but using more of the gluteus maximus. Okay, and then this idea that strength doesn't always equal correct movements. I'm sure you've all had this experience where you did MMT and you're like, okay, that's really strong, and then you watch them walk or do a single leg squat and you're like, what happened? Right? So sometimes this big thing about the motor control, you know, are they using that strong muscles at the right time? Or are they able to wake things up at the right time? Or sometimes they may not know how to turn off muscles. So it's not always about strengthening that's going to get them better, but understanding that nervous system is a huge part of the movement system, and we have to be able to dial it up or down properly. So my patient was doing the, I think the right video is just a couple minutes after, and I asked him to kind of push through and recruit the serratus a little bit better. So this is not a weakness issue, but more of a motor control issue. And this importance about standardized examination. Are we doing the same tests over and over? Because the biggest difference between a novice physical therapist and a expert physical therapist is that the expert PT will be able to recognize patterns. So when they are starting to talk to patients or start to do their examination, they're already picking up on the patterns and coming up with the diagnosis and the treatment. So we want to be the expert pattern recognizer. So for anything below lumbar spine, we do a standardized lower quarter exam. Anything above thoracic spine, we try to do a standardized upper quarter exam. So keep looking for patterns and collect the data like a scientist. Then last slide here is this topic about regional interdependency. So of course, when we look at lumbar spine on Reggie today, that he is an entire human being, and he's got lovely thoracic spine, hip joints that are neighboring the lumbar spine, and so everything is connected. We all know that limb movements affect the lumbar spine. The shoulder is going to affect the cervical spine, vice versa. So these are things that we need to pay attention to. So Reggie, so this is all I have on the slide. If you can tell me how long have you had your low back pain?
Probably about 13 years, and then I had surgery. I had lung surgery, and then the lower back kicked in where it came and started to. I couldn't. My intercostal muscles were cut.
Oh, I see. Okay.
I couldn't contract, so the injury had already been there, so it became worse, obviously. And then I know Mike already. And I started doing what you trained him to do.
Okay.
I think we did 2.5 months, and
right. Okay. So that's it, folks. Okay.
I'm now able to run. I'm now able
excellent.
to do weight training.
Okay.
And I've been doing that. I started at the beginning of January. And running about 30-minute runs, very slow.
Okay, great.
No pain, no lower back problems.
Okay.
And doing basic weights. I have a trainer. He didn't quite make it. He was on his way from Culver City. He was leaving like at 12 o'clock, so obviously he wouldn't make it, right?
That's okay. Yeah.
So
okay.
I don't know.
Awesome. So you're a speech language pathologist here. So does everybody know Reggie? Oh, okay, cool. Okay. All right. Very good. And so at work, are you on your feet or sitting or what's?
Combo, but mostly sitting. I have an outpatient clinic, but I go to the floor and treat patients. I move patients. I do all sorts of stuff on the floor.
Right. Okay. And
not as often as I'm in my office sitting.
Right.
I walk my patients out. I push them into wheelchairs.
Yes.
Sometimes help them get in the car, things like that.
Awesome. Okay. Okay. And do you have pain as of now, or did Michael cure you already?
No, he didn't cure me.
I'm just kidding.
He helped me to be able to do certain movements to help the back not to go out and warm up and things like that. I do get right in the center of my lower back. I get a pain from when I start to work out too much or overdo or do 4 days of workout. By the 5th day, the back starts to not feel so good.
Sure.
I'm still able to walk. Sometimes lean to the left. I have a lean, but everything's leaning to the left. Even my chest, but anyway, that's another story. Chest is like doing that. I was like, what's wrong with this picture?
Okay.
But that's the side of the surgery. So.
Right. Okay. Okay. And do you have any pain right now?
No pain.
No pain right now. And what's the highest level of pain you've experienced for the low back?
For the low back?
Yeah.
About an 8.
About an 8. And when was that? How long ago was that?
About 4 months ago.
Okay. Okay. All right. And when you are doing your work tasks, do you have flare-ups or symptoms?
I do, based on how I moved in the chair or how I got out.
Okay. Okay.
Quick movements.
All right.
Jerky movements.
Okay. All right. sounds good. And anything going down the buttocks, just localized, like
just localized, right, left, or center.
Okay. Okay.
I mean, L2, L1, L2.
Okay.
Right, so
Okay.
right, left. Sometimes the right and the center just really holds in that center.
Okay.
You know, the heat on it and things like that.
Okay. Yeah. Oh, it's okay. It's okay. I like to make my patients comfortable. That's fine. So my goal today is to kind of talk through from the start to finish. How much time do I have until like 1:15? Okay, very good. So I'm going to try to talk through what I'm thinking. I may not be able to. You guys can, I think, refer to Michael for any like the entire list of lower quarter examinations to refer back to. I may not be able to hit up every single one, but it's important to have a working diagnosis after I go through my subjective history taking and then doing the standing alignment assessment, and then kind of pick and choose what tests would be necessary to rule in or rule out the diagnosis. So are you ready for this, Reggie? All right, let's have you stand up. Okay, and then, yeah, is that what you run in, or you came running here like in no sandals?
No, she said don't wear your shoes.
I'm just kidding. Now, do you wear shoes when you run?
Absolutely.
Okay.
Yeah.
Oh, and these days, I guess I should be asking these questions because you just never know. All right, let's have you stand right here. Actually, I'll have you face the TV. Okay. Right. And are you all right if I ask you to? And you can say no if I ask you to take your shirt off, or you can. It's okay. All right. Thank you. Now we can see the whole alignment of the. Yes, please. Thank you.
Guys, be kind.
All right. Good. So much love at the workplace, right? Okay. All right. So it's always nice to kind of step back and kind of get the big picture at glance. Like, first impression is always important. It looks like he's a little bit shifted to the left. Okay, I'm going to put my hands on your crest. Wow, you have long legs. Okay. Okay. It's a little deeper crease on the left side than the right. Okay. And I'm going to go through what we can see from the sagittal plane. I'm looking at frontal plane right now. It looks like just the left side is a tad bit higher maybe. Can you put your feet together, Reggie? Okay. All right. And then spread your feet apart. Okay. Seems a little bit more level. We'll see. Okay. And then I'm putting my hands on his ASIS. I'm not feeling a big rotation as much. I don't know what happened to Reggie's right butt. I think like it. Did you have a farewell party for it? I don't know. It's like not.
It's not there, right?
Yeah. And can you guys see the hollowness on each side, like right here? He's got good contour right here, better on the left. But when you look at the lateral aspect of the gluteals, like something's missing here. Okay. All right. Very good. And then very flat feet bilaterally, more maybe more so on the right. Okay. All right, Reggie. And then I'm going to have you face me so everybody can kind of see the side view. All right. And no pain in standing right now. Okay. All right, so the most prominent thing that I can see here is the increased thoracic kyphosis. The lumbar spine. Now, watch out, guys. For the gentleman patients, you always have to make sure you palpate the iliac crest, because don't be fooled by his shorts, right? Because it's actually up here. Lumbar spine is actually a little bit flat, but I think the thoracic kyphosis makes it look like he's a bit sway back. Okay.
And I have frozen side joints too.
Oh, I see. Okay. Okay. And is it okay for me to ask how old you are?
Sure.
Yeah. How old?
62.
62. Wow. Can we get a round of applause for that, please? Wow. Okay. Awesome. Awesome. Okay. Okay. And then we can kind of take a look at his pelvic tilt. That looks okay to me. And knees. Okay. Okay. So mainly flat lumbar spine, thoracic kyphosis, a little bit of sway back. Okay. All right. So far, I'm thinking about, because of this little bit of a shift going on, my guess is lumbar rotation. So there's 5 choices. Lumbar spine is pretty straightforward. It's either you go into flexion or extension or rotation, or the combination of flexion rotation or extension rotation. So you have 1 in 5 chance that you will be right with your hypothesis. And it's okay to have like a wrong working diagnosis, because I guess you'll find out as you do more examinations. But because of the shift, and you said your surgery was here. Oh, I see. Oh, everybody can see this surgical scar right here. So it was really affecting your breathing. Why did you have to have this lung surgery? Empyema. Okay. I'm not.
The lung. That's okay. The left lung collapsed completely.
I see. Thank you very much for clarification. Yeah, thank you. Okay.
Nice and flat.
So it sounds like you're breathing okay now.
Oh yeah, I'm breathing okay now.
Okay. Okay. All right.
I'm fine.
But because of his, I'm not sure if I want to say like lumbar flexion or lumbar extension. It's flat, so I might think flexion, but he has told me he has frozen facet. So I'm thinking, okay, like the degenerative changes in the spine, he may be leading towards stenosis, which might be more associated with lumbar extension. So I'm going to leave that kind of open. But for sure, I'm seeing asymmetry. So I'm going to call this, we'll say lumbar rotation. I might be wrong. Okay, so now we're going to have you do some trunk movements and standing. So just so everybody can see better, yeah, this is fine. Okay. And I want you to go ahead and keep your legs fairly straight, and then just, I don't care if you can or not, forward bend to.
You don't want the knees to bend?
Yeah, that's good. Okay. And then come on up. Okay. Okay. Oh, and another thing, too, can you guys see from this view that you can see the prominence of that right paraspinal? This is also very asymmetrical, right? So that will also add on to this rotation issue. So this is like very, very, very prominent, and also when he forward bends too. So did you feel increased symptom as you went down or
just
up?
Down, but just back part of the legs.
Mm-hmm. Okay. And then bend forward again, please. Okay, so he's like deviated to the left. This side is still a lot higher than this. A little bit of side bend to the left. Okay, and then come on up. Okay, how do you feel coming up?
Just the center of the back, a little bit of.
Okay, so you have some symptom on both on the way down and up.
Yeah, but coming up, I just felt it right in the center.
Yeah. Okay. Okay. Can you do it again? You okay?
Yep.
You look good there. Okay. And come on up. Nothing. Okay. So when this is as simple as it gets. So I did the primary test. So I watched how Reggie likes to forward bend, and then he had symptoms coming, especially on the way up. I noticed that it was very asymmetrical. So I'm trying to make it where I think he should be, or if he can go that way. So I was trying to reduce this lateral shift. So I guess I'm kind of using some sort of manual skills to kind of guide him into where he should be, and he had less pain. So that's another point for lumbar rotation, as I was trying to reduce this asymmetry when he was coming back up. Okay, all right. It's okay. I'm very kind. Okay. Don't worry. Okay, and then maybe one time of facing this way, and then you doing the forward bending, so people can see the asymmetry. So it is this way. Okay, and then I was just kind of doing this to make him align more straight, and then we were able to reduce the symptom on the way up. Now I'm gonna have you just do a little bit of side bending. Okay. All right, go ahead. All right, and then, so definitely asymmetry. It's easier for him to go to the left. Are you all right, Reggie?
Yep.
Yep. Okay. How is it to the right?
Tighter.
Tighter. Yeah. Okay. All right, and then how about arms across your chest? And then I'm gonna have you just kind of like look to say hello to everybody back here. Okay.
Hola.
Good. And then the other side, please. Okay. Okay, so it looks like it's easier for you to go left. Yeah, you do. Okay. Okay. All right. Are you okay for your symptom? Okay. So this time, I'm just going to have you march in place. Okay. 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 And how are you feeling as you march in place? Fine. Okay. Okay. Not yet. Okay. Okay. It looks a little bit more unstable when he's standing on the right leg compared to when he's doing left stance. Right there. But I mean, it's just like I'm looking for something, but it's not significant. Okay. All right. Great. And let's do. Can you balance on one foot, please? And then the other side. Okay. And one more time on the left. Okay. Looks like he's going to a little bit of hip abduction there. And then the right stance. Okay. Okay, pretty good. Okay. That's fine. And then just face us all here. Can you do like a mini squat, like a half a squat? And he likes to really extend his toes. Like he's all weight bearing on the heels. Okay, it's okay. I'm just, yeah, I know. I'm like horrible about critiquing people.
Don't bend the toes.
Okay, okay. And then can we see you from the side view? Okay. 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 So a lot more like forward lean, and would like to see a little bit more knee flexion there. Okay. All right, that's great. Which table can we use for this one? Is okay? Okay. And then you guys, like, I think some of these, if you want to move and just kind of come closer, I'm totally fine with that. Thank you. Awesome.
This way?
You know, I think I'm gonna have you. Let's see. Will this come up a little bit?
Yeah.
Yeah.
Mm-hmm.
Okay. And then bring the legs up here. Okay, I got you. Mm-hmm. Are you all right?
I'm fine. Thank you. Good job.
Thank you. Thank you so much. I'm barely getting through my test, so you can say that later.
Okay.
Yeah, once you have less pain.
Right. Or have more.
Oh no. Then it's not a good job, huh? Okay. All right. So this is the 2-joint hip flexor length test, or they're now calling it hip extension with knee flexion test, or something like that. But okay, so you're in charge of holding this one.
Okay.
You know what? Let me just double up on this pillow.
I don't have that pillow.
Okay, is that more comfortable?
Yeah.
Okay. And then I'll take your left leg. Okay. All right. Good. Let me have it. I got you. I got you. Good. 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 All right. So I just let this hip go into extension. I gotta make sure he trusts me enough to give me his weight, and he is. Okay. Right about here is, my thumb is on his ASIS, and I'm just watching to see if my thumb starts to move before the thigh hits the table. Because it should hit the table, but right now my thumb starts to kind of shift. So I'm going to abduct his hip, and that's hard to do. Are you all right, Reggie?
I'm fine.
Okay, all right. I'm not hurting you?
Nope.
Okay. Okay, so as I'm trying to abduct his hip, I'm putting the TFL IT band in a little bit of a slack, and then see if he'll go a little bit more. And he does. Okay, but it looks like his knee extends too. Okay. All right. I got you. Yeah. Yeah. It's really stiff abductors. Okay. And the knee extends too. Because the knee's also extending, his TFL and rectus femoris might be stiff. Okay, let's switch side. So that's the left side. Okay. And right. That didn't bother you, Reggie? Okay. Okay, I got you right leg. Good. Okay. Alright. I got you. Okay, and you can relax your foot too. Good. Okay. Okay. It's just kind of wobbly here. Again, he does not like to abduct his leg. That's like so hard to abduct. And then he goes down. Okay. So both sides, the TFL IT band were stiff, left rectus stiff, but more interestingly, the both hip adductors seem to be stiff. Okay, let's go up all the way up on your back. Okay. All right. Good. Come on up all the way. Thank you. Oh, sorry.
It's okay.
I forgot about your. Okay. That comfortable?
Mm-hmm.
Okay. Okay. Now, how are you here? You doing all right?
Yeah.
Okay. All right. So each time we change patient's position, I'm just kind of getting in the habit of asking how they are, because they may have decreased or increased symptoms. And then I'm going to go through again his hip and knee flexion. Okay. And Reggie, can you do that for me, please? Okay. And come on back down. Okay. Once more. Okay. Are you doing all right?
Yes.
Okay. Okay. And then come on back down. Okay. Some rotation. It's not causing his pain, and it's not like the biggest thing I'm seeing so far. So I'm just gonna move forward. Okay. Okay. It's okay. I got it. Yeah. Okay. And now it's your turn, Reggie. Okay. Okay. And back up. Okay. Yeah, that's a little harder. Okay. Okay, no pain?
Just tightness.
Just tightness. Yeah, I can see that. I felt it too. Yeah. Okay. Okay, so it seems like he has a hard time letting go of the adductors, so kind of seeing this ratchety-like motion, and then you guys kind of may have noted a little bit of lumbar pelvic rotation here. Okay, I'm going to, let's see. I think I'm going to skip the straight leg raise test because that's more hip specific. Okay. Okay, that seems fair. Okay, that's just kind of clearing to make sure that he has enough internal external rotation, that it's pretty symmetrical. I'm going to do the same things on this side. Okay, I got it. Okay, and he's got long legs, so this is like heavy. That's good. You okay there?
Mm-hmm.
All right. And then now it's your turn to go ahead and pick up your left knee and okay, and then bring it back down. Okay. Once more. Okay. Okay. No pain?
No.
It's just subtle, like this. So I'm keeping that in my mind. Like I'm not impressed with his impairment. I guess Michael did a good job. No. Okay, and then let me have this knee. It's okay. Good. Again, it's just kind of hard to AB duct laterally rotate his hip. Okay, and then your turn. Okay. Okay, and then come on back. Okay, you guys can see that he has about this much motion, but before he gets there, his lumbopelvic region starts to kind of come along with it. So again, these rotational problems coming up. Okay. Okay, good. Okay. And then it's nice to check hip rotation in both extended and flexed positions. So these are real quick tests that you guys can do. A little bit more limitation on the left hip mobility, especially lateral rotation. I'm not hurting you? No. Okay. Okay. Good. And then on your side, please. Okay. Great. And then I'm going to bend your knees a little bit more. Okay. So I'm just aligning so that we're making a straight line from shoulders, hips, all the way to the feet. Okay. All right. And you're okay here?
Yes.
Yeah. Okay. Do you have any issues with sleeping at night? Does your back bother you at night?
Sometimes.
Sometimes.
Yeah.
How do you? What's the position that you sleep in usually?
I usually sleep on my left side.
Left side. Okay.
And,
Okay. Okay. So we'll take a look at that on the left. Okay. All right. I got you, Reggie. I got you. Okay. Don't help. Okay. Good. 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 Yeah. I wanna feel how heavy your thigh is. Okay. You okay? Mm-hmm. Okay. All right. So that same motion, can you do that on your own? Okay. Good job, because you failed that one pretty bad. Okay. Okay. So you can see my left hand. As soon as he goes, go ahead. Okay. So this we would like to see him just being able to move through the hip joint without affecting his lumbar spine. And so again, all these rotation things are keep coming up. Now let's say, and I assume you're doing okay. Like this isn't so painful. Let's say if the patient did have increased pain with that. In this case, this is like low level for him, so it's not bringing up his symptom. If they did, that would be a positive primary test, and then you would want to follow up with a secondary test to see if you can reduce their pain. So I might say, hey Reggie, can you make sure you don't do this rolling over thing? You just hold this part still, okay, as you open up the knee, okay? Here we go. Good. And that's good. Okay. Was that hard? Okay. Okay. And of course, you guys can, there's so many different cues that you can give the patient. Every patient responds differently to different cues. So whether that's going for the abdominals or trying to wake up the hip abductor lateral rotators, or just simply telling them what you want to see. And as long as the desired motion is seen, you've just given them a new home exercise. So that's fine. And then you guys remember too that when I was going through some of the other tests that we kept saying, hey, hip adductors are sort of really stiff, and he has a hard time letting that go. So when he's trying to AB duct laterally rotate, that's a lot of effort for him to overcome lengthening those hip adductors. So I can appreciate why that would be hard. Plus his long legs, it's just, it's just so long. Okay. Okay. Yeah, so it's fine for me to take him into hip extension, but to AB duct, I'm like, this is my workout for the day. Let me just do a few more reps. Okay, just kidding. Okay, hold it here, and I gotta make sure that he is using the posterior gluteus medius here. Are you okay? Hold it there, hold it there, hold it there. Good, good, beautiful, good. Let it go. Okay, nice job, Reggie. And then I want you to go ahead and come up and then back down. Okay, ready? Good, good, good. Okay, and good. Come on back down. So he has great strength in the gluteus medius, but what he wants to use when he tries to abduct the hip is his TFL, because he's kind of going into a little bit of hip flexion. Okay, so are you able to come up like straight up this way? Got your top leg. Okay, bottom leg straight, please. Okay, and then let's lift up the bottom leg. Are you good? Hold, hold. Okay, very good. All right. On your stomach, please. Okay, let's see how you are without any pillows first. Okay, and then for your face, maybe like this. Okay. Yeah, okay. Reggie, I'm gonna place this pillow underneath your belly. See how you look. Okay. Can I use this one too? Okay. Let's lift up one more time, Reggie. I'm putting a little bit more support. Okay. Because of his thoracic kyphosis too. So. Okay. Are you all right there? Okay. 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 We'll just keep marching along. All right. See, he's already like really adducted too when he's in prone. How are you feeling here? You okay? Can you guys see? Can you guys see the difference here? Okay, we're admiring your gluteals. Just the left one. I'm so bad. Okay. All right. Are you okay? Okay. You good? Okay. Give me a workout, Reggie. That's great. I love working out. Okay, so this feels really stiff. Okay, and then can you bend your knee for me, please? Okay, can you guys see that? Go ahead and put it back down. Okay. All right. Bend your knee again. Okay. Yeah. Now, granted, it is happening at the very end range, but that is not an acceptable standard knee flexion in prone, right? And then he's doing a lot of pelvic rotation and some anterior tilt. So, did you have pain with that, Reggie? No pain. Okay. Okay. Can you bend your left knee again? Do you feel a stretch along the thigh? Yeah. Okay. Okay. All right. That's fine. Okay. No pain? No pain. All right, Reggie, can you move your foot from side to side like that? Okay. Okay, great. Okay. I know, guys, I'm not reproducing his pain, but if they were painful, I would have asked him to just kind of hold that pelvis a little bit more stable and then just really isolate his ability to move just from the hip. Okay. Okay, my turn. My turn. It's okay. I got you. I got you. I'm just going to bend your right knee. That's all. Okay. I mean, there's already like it's already work for me here to get through the end. But notice how his back isn't shifting so much. Let's see what happens when you bend your knee. Better here. Okay. And put it back down. Okay. Yeah. Okay. Okay. And just easily bend your knee. Just easily bend your knee. Okay. Okay. You okay?
Mm-hmm.
Okay, that's better. Okay. Is that like a lot of work for you? No?
Concentrating that.
Okay. 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 And then I'm going to have you go through the side-to-side motion of the foot, okay? Okay. So to me, when he moved the left leg, the lumbopelvic rotation was much worse. This side, better. Okay. Okay, great. Can you hold this here? Mm-hmm. Okay, you got this. Use this one. Mm-hmm. You all right? Mm-hmm. Hold it there. Mm-hmm. Hold it there. Mm-hmm. Sorry, Reggie. Okay. Okay. I can't call that 5 because it just gives a little bit, maybe 4+. Okay. I got you. Okay. Hold it here. Good. You okay? Hold. Hold. Big difference. Okay. You all right? Mm-hmm. Okay, so solid 5 out of 5 there on the left gluteus maximus. Okay. Great. And then I'm going to have you go on to your all fours on the table. Mm-hmm. Okay. I'm going to move this out of the way. Okay. All right. You okay? Mm-hmm. Okay. And then I'll just have you bring your knees up a little bit so that they're right underneath your hips. Good. Okay. All right. So we've got this. Oh, this is structural. Might be structural thoracic kyphosis. Okay. How does it look from the back? Okay, very asymmetrical. Okay. Now, Reggie, are you able to just leave your hands right here? Your arms are straight, but I'm gonna have you just relax your chest. Okay, good, good, good. Now, good job. Keep it there. A little pie in the face. Just lift your head up a little. Okay. 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 Okay, so if like somebody has like fixed kyphosis, I wouldn't have been able to change that alignment. I'm just using gravity to see if he can flatten out a little bit more, and he can. It's just maybe a little overactive on the adductors, but let's see. Okay. So a little bit higher on the right side. I'm just talking out loud, Reggie. Okay. You don't need to change anything. But that's very consistent with what we saw in forward bending. Right. Okay. Let's go ahead, and if your knees or anything do not hurt, just sit back towards me. Okay. Okay, and come on up. All right. Now, I think if we're coming from this view, you guys can appreciate the asymmetry. He just, let's go back again. Okay, and feel free to move, guys, so you can appreciate this asymmetry. Okay. Stays higher here, but is it easier for you to bend this side? It doesn't look like your left hip bends as much. Yeah, okay. So the paraspinals are higher on this side, but the pelvis itself is a little lower on the right. So it looks like he easily moves, let's see, with the right hip. Okay, let's see. Ready? Go. You feel okay? Mm-hmm. How does it look? Oops, sorry. Mobilize something. I didn't know I was a manual therapist. Just kidding. Okay. Okay. So lots of asymmetry going on. Okay. That was no pain. That was no pain. Okay. And then last thing here, I'm going to have you just raise your arm up and down, just one at a time. Okay. Okay. And then back down. And the left. Okay. So you guys can see, okay, so even the upper extremity movements too, creating this rotational stuff. Okay, and then have you sit down at the edge of the table. Okay. 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 And then, is this how you sit and do your charts?
Yeah. Probably.
Maybe.
No,
maybe. Okay.
Hope
okay.
not.
You use a backrest for when you are charting? Hold here.
Yeah, I do.
You do? Okay.
Oh, just hold. Okay.
Yeah, hold. 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 Great job. Okay, let it go. Okay. Yeah, you know what? Let's see. It's so much easier to flex the right hip. And that's why he's got that rotation when he's in quadruped. It's just a little harder to move this hip. Okay. Here, hold. Hold. Okay, hold. That's fine. That's great. Okay. All right, Reggie. So I'm pretty happy with my working diagnosis of lumbar rotation. Okay, everything that we've done from the beginning through the end, the one thing that kept coming up was this shifting around. Okay, so whether you were trying to move your leg, the low back started to give. And with the facet joints facing this way in lumbar spine, it's not really well designed for doing a lot of rotation. So it would be nice to get more of the rotation from maybe thoracic spine or hip joints. So to eliminate that wiggling from side to side with many of the things that you do, that would be important.
Mike, you got that?
Okay. And you know, these things can evolve as patients, you know, get better with controlling one direction. You know, it may change. I don't know what his original movement diagnosis was. I did not cheat. I didn't talk to Michael at all about his case. But when you are sitting, if you go into, if you start to slouch a little bit, allow the spine to flex, that opens up the facet joints, which sounds like a good deal, but when you have the facet joints open, you can rotate easily. Okay, so in order to really get to the point of not twisting so much with all the things that you do, like I think a quadruped, you may need a little more help from these wonderful folks here, just to kind of, hey, am I doing this right? Kind of thing, because you are quite asymmetrical when you're on quadruped, but it's a nice way to just kind of close down on the facet joint so you can't rotate as much, and then maybe get a little bit better motion through the left hip. Or know that, hey, I can't go any more than this on the left side, so I better stop right here. Because if you keep going, then you're going to have this rotation thing, because that right hip moves so much easier than the left hip. And then I'm like almost out of time. So realistically, then I would spend the last 15 more minutes of my initial evaluation time to go ahead and go through the more important things, like when he's walking and hopefully going into like single leg squats and then like running type of stuff to kind of tie in all of this together, and then educate him on, all right, so here's how I want you to sleep, and here's how I want you to sit and do your charts, and try not to like reach for things like this. Is swivel the chair so that the whole body's going with it. Those little things, right? So dishwasher, you wash the dishes, and you're loading, pick up your feet and get everything squared up. I mean, every little thing just counts. I know. Don't show off your long arms. I mean, it's like, it's okay. It's okay to take that extra step, you know, because that or that is going to most likely come from the low back. Okay, so big picture is try to minimize the twisting that's happening. Okay, and then home exercise wise, like you can work on that side lying, like opening up the knee. But that's like giving an exercise is giving people an additional skill, right? It doesn't always transfer to functional activities. So more importantly, like let's really quick, can we watch you walk back and forth here? Okay, really quick. Okay. Okay. Don't run away. Okay. Okay. And then, Reggie, can you put your hands on your pelvis? Okay. All right. Just walking. Okay. All right. Do you guys see the little blip when he's on right stance? The right hip abductors, the right gluteals is the weaker side for him. So, Reggie, when you stand on the right, here is where you get a little sexy, just a little sexy. Here. Okay. I know. So, and it's not bad, okay? But I want you to just kind of keep both of the hands little bit more I make no gender judgments. I make no gender judgments. Okay. So just kind of keep these a little bit more level, okay? Especially when you put your weight on the right foot, okay? Okay. So like, I think having him focus on that some percentage of the time that he's on his feet might be functionally better than doing like 20 times of clams on each side, because that doesn't mean he's going to walk differently. So I would emphasize more of what he can do functionally. I think the best sales pitch for educating patients is if, like, I'm hoping that they're going to have some kind of pain as I'm going through these examinations. Like, please, that looked awful. Please have pain. And then
I did have it with Mike.
Okay, all right. Yeah, and then you try to correct them and kind of guide them, and you know, they really can trust you, because by the end of these things that you've eliminated some of their pain. That's that. Yeah. Okay, sorry I ran a little bit over. But yeah, thank you so much. Michael has my information. I guess I hope to see many of you guys in May. Is that right? So yeah, I hope this was, I had fun. I don't know about you guys, but I had a lot of fun. Thank you so much for having me. Thank you. Yeah. Yeah, good. Oh, good. All right. All good review, right? Good. Okay. Yeah. Thank you so much.